Greece well, some of the islands very well, and I'm always very happy to come back. So I'm going to give you a brief history of rehabilitation. It's very selective, and some of you will think I should have included people I haven't included, so I apologise for that. Then I'm going to talk about what rehabilitation is like now, and then where I think we might be going in the future. So, the earliest known description of treatment of head injury, as Pierre North said yesterday, is from an Egyptian document of 2,500 to 3,000 years ago. This is the Edwin Smith papyrus discovered in Luxor in 1862. But if you read a translation of that papyrus, it's more medical treatment, I think, than what we'd see as rehabilitation today. And current rehab really began in World War I, particularly in Germany. Although this is an American photograph taken in 1917, and it's the, I thank Corwin Boke for a copy of this photograph, but it's the first known photograph of soldiers in World War I having rehabilitation. And they're having occupational therapy, and occupational therapists do not like the image of basket making and weaving, but that's in fact what these were doing. So the reason it began in Germany in World War I was because of neurosurgical interventions. Now, they were introduced in America by the American neurosurgeon Harvey Cushing, and soldiers were treated immediately at the frontier. So more people were surviving. And because they were surviving, things had to be done to help them. They were transferred to neurological departments that took place as soon as it was considered possible. But the first neurologists to treat or rehabilitate were the Germans Walter Poppelreuter and Kurt Goldstein. Now, Poppelreuter, there's a photo of him, he wrote the first ever book on brain injury rehabilitation in 1917. And it's been translated into English. I think that was translated in 1981. So he worked with the soldiers in Germany, these survivors of gunshot wounds to the brain, and he published the first book on rehab. And in this book, he described his treatment of soldiers with visual spatial and visual perceptual disorders. He also discussed vocational rehabilitation. And there's a whole chapter at the beginning of the book on vocational rehab. And if you read that chapter, many of the things we do in vocational rehabilitation today were described by Poppelreuter in 1917. But perhaps the most famous man, and I know Yehuda's going to be talking about him tomorrow, is Kurt Goldstein. Very important man at the beginning of brain injury rehabilitation. So he worked in Germany in World War I, moved to the United States for obvious reasons just before World War II, and spent the rest of his life in the USA. Goldstein's main publications were The Organism, published in German in 1939 and in English in 1963, and it was a book describing a holistic methodology of science. And he also produced The After Effects of Brain Injury in War in 1942. And this was a book about rehabilitation procedures, including more than a decade of follow-up studies. So in Goldstein's procedure, the soldiers were treated acutely at the front and then transferred to Frankfurt to a milieu therapeutic department. And evaluations there were performed by psychologists. And in case you don't know, I'm a clinical psychologist specializing in neuropsychological rehabilitation. And Goldstein also set up a school and a workshop for these soldiers. Now, we move forward to World War II. Unfortunately, many of the advances in brain injury rehabilitation are the result of wars. But in what was then the Soviet Union, the army general, the neurosurgeon Burdenko, made Alexander Romanov-Luria, who was Nick Goldberg's teacher for a while, he made Luria the chief of a rehabilitation hospital in the Urals. And here, Luria continued his theoretical work and his development of methods for evaluation, and that included methods for rehabilitation. He later published Traumatic Aphasia, and one of his really important books, I feel, was Restoration of Brain Function After War Injuries and Higher Cortical Functions in Man. And this is a photograph from 1973 of Luria, who many consider to be the grandfather of neuropsychology. And here is Luria investigating a patient. There's also contributions from Britain, I have to say that, being British, during World War II. Mobile neurosurgical units were formed close to the front line, and that was the neurosurgeon most involved then was Hugh Cairns, and they had prompt and expert management of physical and neurological disturbances when they came back to England. They were treated in Oxford. And the neurologist there was Richie Russell, and the neuropsychologist, Frida Newcomb, who died a few years ago. And this included long-term monitoring. In fact, Frida published a paper of these soldiers like 40 years after their initial injuries. So they monitored their physical, emotional, and social progress. And then there was Oliver Zangwill's work. Well, during the war, he wasn't working in Cambridge, but after the war, he became Professor of Psychology in Cambridge until he retired in 84, and he died in 87. But this is a young Oliver Zangwill, and during World War II, he worked in Bangor Hospital, which is just outside Edinburgh in Scotland. And he worked with British soldiers who'd survived brain injuries. And this is a photograph. And this, Pierre, is for you, this photograph, because this is Oliver Zangwill, much older than the previous photo, and this is MacDonald Critchley, who we were talking about last night. MacDonald Critchley was a neurologist who wrote a wonderful book called The Parietal Lobes. And if you can ever get that, it's out of print now, if you can get hold of that book. And here is the wonderful Luria, and this is Lord Brain. And I recently met his granddaughter, who asked me for a copy of this photograph. And then we move on to yet another war, the Yom Kippur War. And here we meet Yehuda Ben Yishai. You look slightly different there, Yehuda, but still beautiful.
The nose is still the same.
The what's still the same?
The nose.
The nose is still the same, right. So there was a joint project of the Israeli Ministry of Defense and the New York University Institution of Rehabilitation Medicine by Leonard Diller, who sadly, he was supposed to be giving this talk, but he was unable to come because his wife's not very well, so I'm doing that talk instead. And Yehuda was asked to go, I think I've got this right, Yehuda. You were asked to go back to Israel to set up a program for the Israeli soldiers that had survived gunshot wounds to the head. And you set up a day treatment program in 1975 in Tel Aviv. And that was the forerunner of the current holistic rehabilitation programs. Now, this is a photograph of Leonard Diller with Annalisa Christensen. And this was actually taken in 1985. Now, I wanted to put these two up because Leonard Diller, who many of you will know and who should be here, but I think what was interesting to me is he set up the first program to call itself cognitive rehabilitation. And this was in 1976 in New York. Now, I think people had been doing cognitive rehab before that, but they hadn't been using that name. So Diller's was the first program set up in 1976 to call itself a cognitive rehabilitation program. But the other interesting thing about Diller in my sort of apprenticeship was he was one of the first people to publish on rehabilitation of unilateral neglect. And some interesting early papers came from that group. And Annalisa Christensen, she set up a program in Copenhagen in Denmark, very much influenced by Yehuda Ben Yishai and the holistic principles. And this is the centre in Denmark, where I think I met Nick there for the first time. I met Don there, and Annalisa has now retired, but I was actually there last week as well. And then to George, hope I get this right, George, who very influential in brain injury rehabilitation, not only in the USA, but worldwide. And George set up a program, again, influenced by Yehuda's, first in Oklahoma City, and then he moved to Phoenix, where I was fortunate to spend 3 months working with him in Phoenix. So just to and I know I've missed a lot of people out, but I've had to be selective. So first known photograph, Kurt Goldstein, Walter Poppelreuter, wonderful photograph of Luria. I don't know if you know this one, Nick, but this is Luria catching a sturgeon, and he sent it to his great friend Oliver Zangwill in England, and after Oliver died, his widow gave the photograph to me. So it's a special photo. Young Oliver Zangwill, Yehuda Ben Yishai, Leonard Diller and Annalisa Christensen, George Brigatano, then a few other people I haven't talked about, but I think have been influential. Catherine Mattia, Lance Trexler, myself, modestly puts in, Jim Marlek and Keith Cicerone, who've done some very important meta-analysis of cognitive rehabilitation, Jenny Ponsford from Australia, Robin Tate from Australia, Jonathan Evans from the United Kingdom, and Nick Alderman from the United Kingdom, who's done a lot of very interesting work of brain-injured people with very severe behaviour problems. Okay, now, so that was my brief foray into history, and I'm now going to tell you how we set up our centre, the Oliver Zangwill Centre, in the United Kingdom, because I think it's an interesting story from wherever you work on how you can influence what happens in your own health services, in your own countries. So I did a sabbatical with George in 1993, and I had a very interesting 3 months there, and I remember on one occasion I was sitting in a discussion about the patients, and I had this flash of revelation, and I thought, if any of my family ever needed rehabilitation, this is the kind of rehab I would want them to have. But I wouldn't want them to have to come to the USA for it. So I go back to the United Kingdom, very happy to go home, and I met a man called Tony Jewell from the National Health Service, our health service. And Tony Jewell was, he was a trained doctor, but he was working in administration in the health service. And I told him I wanted something similar to George Brigatano's unit, but in the United Kingdom. And I also wanted to maybe change it a bit and put into practice the principles of rehabilitation that I hold dear. So I talked to Tony, and he said, well, put in a business plan. And I thought, well, that will come to nothing. But I did the business plan. I wrote out the business plan, and a series of meetings followed. So many, many meetings then between my employers, the Medical Research Council, the hospital in Cambridge, various other people, lots and lots of discussions. And it took us 3 years before we got agreement from one of the local health authorities, and the chief executive was Richard Taylor, and he phoned me up at home one evening and said, you can go ahead with your new planned rehabilitation centre. Now, while I was doing this, I attracted some very powerful allies from within the Medical Research Council, particularly, but also some enemies. And unfortunately, these were some people from the medical profession in Cambridge. Not all of them, but some of them. And one neurologist said, I would like to strangle it at birth, which wasn't a very nice thing to say. But we won. Now, then I had to choose a name for the centre. Now, I wanted it to be someone who'd influenced rehabilitation, someone who was British, because it's a British centre, someone who had died, so I didn't offend anybody, And he had to have a nice name. And I thought Oliver Zangwill fitted the bill. And we opened the centre in 1996. And it just shows that clinical psychologists like me, I'm not medically qualified, I'm a psychologist, partly in research, partly in clinical work, but you can influence healthcare practice. And so that was an example of that. Now, I just wanted to say a bit more about Oliver Zangwill. Who was he? Well, like you, Nick, his family originally came from Latvia. So he was born in 1913 into an interesting and distinguished family that had emigrated to London from Riga in Latvia in the 1860s. And Oliver's father, Israel Zangwill, was a novelist and a playwright who wrote comedies and tragedies about the ghettos. And one of his murder mysteries was made into a silent film. And there's a street in Greenwich in South London which is called Zangwill Road, and that's named after Zangwill's father. And his grandmother was one of the first women doctors to practice in England, but she had to study in France because women were not allowed to study medicine in England at that time. And her thesis was examined by Paul Broca, where we get Broca's aphasia. Now, I don't know if anybody knows this man. This is Richard Gregory, who wrote a wonderful book called The Eye and the Brain, which I recommend you to read if you haven't read it. And Richard Gregory was a great friend of Oliver's. And he reports that Oliver's first recorded experiment took place when he was 8 years of age. And Oliver knew a woman who claimed she could always detect, she always knew when a rat was present. She had this sensitivity to rats. So Oliver hid a rat under his collar and then went to kiss the woman, and she had no idea he had a rat. So that was his first experiment. This is another young Oliver at Cambridge University. And he told Richard Gregory, Oliver told Richard Gregory, that this time that he spent in Scotland with the soldiers in World War II, that was the most creative period of his life. And it was during this period that Oliver became one of the pioneers of brain injury rehabilitation, whose papers are still worth reading today. And this is the photograph I mentioned earlier. He was a friend of Alexander Luria, and this photograph was sent to Oliver by Luria sometime after World War II, and it shows Luria catching a sturgeon, and Shirley Zangwill, Oliver's second wife and widow, gave this photograph to me in 1996. And an important paper by Zangwill, published in 1947, on rehabilitation of people with brain injury. And in this paper, he discusses, among other things, the principles of re-education. And he talks about three main approaches: compensation, substitution, and direct retraining. And as far as we know, he was the first person to categorize approaches to cognitive rehabilitation in this way. All right, now I'm coming on to current rehab. So this is my favorite definition of rehabilitation. It was by Lindsay McClellan, who's a neurologist and a professor of rehab, and he was actually my boss for 3 years when I worked in Southampton. And this is what the definition says: rehabilitation is a process whereby people who are disabled by injury or disease work together with professional staff, relatives, and members of the wider community to achieve their optimum physical, psychological, social, and vocational well-being. Now, the reason I like this so much is because it's seeing rehabilitation as this process. It's not something we do to people or give to people. It's not drugs or surgery. It's where we work together with the person and their family members and members of the wider community. So that's one reason I like it. I'm also very much approving of the fact that McClellan, a neurologist, is concerned with psychological well-being. And it also illustrates that rehabilitation is not synonymous with recovery, which I think some people get confused with. You will even today hear people say there's no evidence that rehabilitation works. Well, there's a lot of evidence that rehabilitation works, but there's no evidence that rehabilitation restores people to their former level of functioning. Now, this is my definition of cognitive rehab, very much influenced by McClelland's. So cognitive rehabilitation is a process whereby people with brain injury work together with professional staff and others to remediate or alleviate cognitive deficits arising from a neurological insult. And neuropsychological rehabilitation is similar to cognitive rehab, but it's broader. So neuropsychological rehabilitation is concerned with the amelioration of cognitive, emotional, psychosocial, and behavioural deficits caused by an insult to the brain. And the main purposes of such rehabilitation, the main reason people like me are in rehab, is to enable people with disabilities to achieve their optimum level of well-being, to reduce the impact of their problems on everyday life, and to help them return to their own most appropriate environments. That environment may be going back home and getting back to work, it may be going into a nursing home, and it may be anywhere in between. But wherever they're going back to, it's got to be the most appropriate one for them. And the purpose of rehabilitation is not to teach people to score better on tests, or to learn lists of words, or to be faster at detecting stimuli on a computer or whatever. We don't do rehabilitation to make people better at tests. I'll be talking more about assessment later this morning when I do the theoretical understanding of rehab. Now, I picked out what to me seem to be some of the most important developments in recent years. Other people would choose different ones, but you've got an idiosyncratic point of view here. But one of the big changes that's come in since I first started in rehab in the 1970s is this partnership with patients and families. Another big change is that most of our rehab now, and certainly all the units in the UK follow this pattern, is to use goal setting to plan and partly to evaluate rehabilitation. A third big change has been the recognition that cognition, emotion, and behaviour are interlinked, and that's one of the core characteristics of the holistic approach. Then rehabilitation should start in intensive care. An increasing use of technology to help people compensate for their difficulties, and I'm particularly interested in technology for compensating for memory deficits, but of course there are others for speech problems, visual spatial problems, even imaging, I suppose you could say, is a technology. And the final one I wanted to touch on is that we now draw upon a very broad theoretical base, or as Diller once said, several theoretical bases, because no one model or framework or approach or theory is sufficient. Okay, so the partnership with families and patients and families. Now, when I started in rehab in the 1970s, it was the doctors or psychologists or therapists. We would decide what people would work on or aim for or achieve in rehab. We would say things like, we're aiming for wheelchair independence, or our goal is to teach him to use a new communication system. But we'd decide. And that's completely changed now, at least in the rehab I work in. We always negotiate with the families and the patients. And we negotiate goals. Now, sometimes we have to be, the goals the families want are very different to what we want. They might say, my goal is to get my memory back. So that's where we have this art of negotiation. Well, I don't think we can actually do that, but we might be able to find a way to help you remember what you have to do each day. What about having that as one of our goals? It's that kind of thing. But the principles of goal planning involve the patient. The goals should be reasonable. The goals should describe the patient's behaviour, so don't say improve memory or improve concentration or improve walking. It's too vague and you can't measure it. But you should say something like, Paul will be able to work for 15 minutes in occupational therapy before leaving his seat, or something like that, or be on task for 15 minutes if you're working on concentration. Or John will be able to remember to take his medication independently 3 times a day for the next, for however long he needs it. You have to set a deadline by which this can be achieved, and you have to spell out the method by which you're going to achieve this. And that should be sufficiently clear and specific so that anyone reading it would know what to do. And the goals must be SMART. And that's an acronym which stands for specific, measurable, achievable, realistic, and within a time frame. So if your goal is to, if you're going to set any goal for anybody in rehab, you should be saying to yourself, is this a SMART goal? Is it specific? Can I measure it? Is it potentially achievable? Is it a realistic goal for this particular patient? And decide by which time he or she has to achieve the goal. Then the increasing recognition that cognition, emotion and behaviour are interlinked, which is the holistic approach, pioneered by Yehuda Ben-Yishai and George Prigatano. And just as a little aside, the theories and models of emotion, which is particularly important in the holistic approach, are becoming increasingly important in any cognitive rehab. And they may arise at least through 3 reasons. The emotional problems may arise because of neurological factors. So, for example, somebody with frontal lobe damage may have loss of control and be disinhibited. They may arise through psychological factors. So somebody who can no longer read or remember things may have reduced self-esteem. They may arise because of psychodynamic factors, so they may become very socially isolated following brain injury, and people may have all 3 of these reasons contributing to their emotional difficulties. And by the way, I should thank Guido Gianotti for this framework. The holistic approach regards it as futile to separate the cognitive consequences of brain injury from the emotional, social, and functional consequences, because how we feel affects how we think, how we remember, how we communicate, how we solve problems, and how we behave. These functions are interconnected, they're hard to separate, and all of them need to be dealt with in rehabilitation. And what holistic programs try to do is increase awareness, acceptance and understanding, alleviate cognitive deficits, help people develop compensatory skills, provide vocational counselling, offer both group and individual therapy for all clients, and use an interdisciplinary approach, not just a multidisciplinary approach, but an interdisciplinary approach, where the borders between the different disciplines are blurred. We work together. Rehabilitation shouldn't be divisive. You shouldn't be saying the role of the psychologist is this, and the role of the occupational therapist is this, and the role of the speech therapist is this. We are all working in an interdisciplinary way together. And that doesn't mean, of course, that we don't make use of people's particular skills. I mean, in our centre, the psychological support group and individual psychological support would always be given by the psychologist. The communication problems would always be dealt with by the speech and language therapist and so forth. But when we're running groups, like Understanding Brain Injury Group, then the different disciplines work together, and the same with the problem-solving group or the memory group or whatever. Now, this particular one I'm going to skip because I'm talking about this in my next talk just before lunch. So I'm going to move on now to rehabilitation should start in intensive care. And a few years ago, I got very interested in working with people in the vegetative state and the minimally conscious state because of some interesting work going on in Cambridge. But before that, I spent 20 years almost developing a new tool to monitor recovery from severe head injury called the Wessex Head Injury Matrix, an observational tool, which some of you may know about if you work with that group of patients. And our tool was developed after observations, some very detailed observations sometimes, of 88 patients recovering from severe traumatic brain injury. And that's a very easy thing to say, but it's very hard to do. It takes years and it takes a lot of practical sorting out of problems. But we developed this tool and we used it not only to assess people as they're recovering, but we could use it to set early rehabilitation goals. Now, the goals there are going to be very different from the goals in later stage rehab. It might be a goal such as getting this man to look at somebody when they're giving him attention, or getting him to track a simple flashlight, or establishing a yes-no response. It will be those kind of goals rather than goals to do with driving or getting back to work. Now, I'm just going to show you 3 brief video clips here. The first one is a man in coma. He was one of the people in our study of the 88 patients we observed recovering from severe TBI. But so you'll know that coma is not opening the eyes, not obeying commands, and no verbal response. So just check that he's not doing any of those things.
Andy, can you squeeze my hand? Can you squeeze my hand? Can you squeeze my hand, Andy? Andy, can you squeeze my hand? Squeeze my hand, Andy.
Okay, now, oops, didn't want to do that. A few weeks later, Andy has become vegetative. Now, the vegetative patients are not very different from patients in coma, except they open their eyes. So a cycle of eye opening and closure is present, but then there's no other reaction or interaction with the environment. So just check now. I think you can see that his eyes are open, but he's not doing much else.
Good, keep going. Come on. Come on, Andy. Right centre. Right round. Come on, that's excellent. Go on, keep going. Doing really well. Round this way. Round this way. Good, come on. Straight past the camera now, round towards the left. Around and have a look at Claire. Come on. Turn your head round and look at Claire.
Okay, so he has got his eyes open, but he's not doing anything. They're saying, good, good, you're doing well, but he's not actually doing anything. He's not moving his head to their commands at all. Now, this is the next stage. This isn't Andy, this is a different man. This is the minimally conscious state, where there's some meaningful but very limited interaction with the environment. And what you'll see here is that the 2 physiotherapists talking about the patient, this patient is actually looking at one of them. And that's the only meaningful interaction with the environment that he's showing. But he's beyond the vegetative state, but he's still not fully conscious. Oops, sorry. Try this again.
I've actually changed it to 2 times 3 hours.
Right.
I think it'll be easier for them. And seeing as his heel's been fine, I think that would be...
You've actually been very good with it.
They have. I don't want to make it harder than,
Okay. Now, so the severity of brain injury, as most of you will know, is measured by the depth and duration of coma, the duration of post-traumatic amnesia. They're the two main ways of measuring the severity. And coma is no verbal response, not obeying commands, and not opening the eyes spontaneously or to stimulation. The vegetative state, and this is the Royal College of Physicians in London, their definition. So no evidence of awareness, no volitional response, and no evidence of language comprehension. A cycle of eye opening and closure is present. Hypothalamic and brainstem function may be intact. And further clinical features include incontinence, spontaneous blinking, occasional movements of the eyes or head, aimless movements of the limbs or trunk, and maybe facial grimacing. And the minimally conscious state, there's inconsistent but meaningful interaction. So there's arousal and possibly sustained tracking. But the behavioural repertoire is very severely compromised, very limited self-awareness as far as we know. They do appear to feel pain and have sleep-wake cycles, a severely limited movement. It's not always easy to distinguish between vegetative and minimally conscious state. But the WIM, that's the Wessex Head Injury Matrix I talked about earlier, that can help in the differentiation of these states. It's certainly more sensitive than the Glasgow Coma Scale, and I'll show you some evidence for that in a moment. It can predict to some extent what behaviours are likely to occur next, although this isn't set in stone. It certainly can suggest early rehabilitation goals, and it's currently used in a number of research studies as well as clinical work. So the WIM, it comprises 62 items of behaviour. We originally observed 162 items in these 88 patients. So 162 items, different items of different behaviours. But some of those were very similar, or we'd only observed them once. So we collapsed it into 62 items. Now, the very first one is eyes open briefly. So at that stage, it overlaps with the Glasgow Coma Scale. Going through to number 4, attention held momentarily by a dominant stimulus. So you hold up a brightly coloured ball and see if they can look at it for 2 seconds or more. Then going right down to number 32, indicates understanding by a head shake or a nod or a gesture, and they have to get 9 out of 10 correct within one assessment session for that to be counted. Number 45, smiles. Now, out of 62 behaviours, smiling is actually quite late, because a baby of 6 weeks of age will be smiling. So it comes very early in the social behaviour of a child, but quite late in the recovery from severe traumatic brain injury. But it's not true of everybody. So some people will smile quite early, but others, the smiling comes late. And then some of the relatives will say to you, well, I know he's awake and I know he's recognising me, but he won't smile. And it's quite reassuring to say, well, we wouldn't expect to see that just yet. That will come a bit later. And the penultimate one, the one before last, is remember something from earlier in the day. So have you been to physiotherapy yet, for example? And the last one, 62, is out of post-traumatic amnesia. Now, I said it's more sensitive than the Glasgow Coma Scale. So in one small study, we looked at vegetative and minimally conscious patients, all of whom scored 10 on the Glasgow Coma Scale. So they're not in coma, but they're not doing very much either. But they're all look the same on the Glasgow Coma Scale. They're all getting 10. But on the WIM, the Wessex Head Injury Matrix, they're scoring very differently. Now, HR stands for highest ranked behaviour. So out of the 62, what's the top one they managed to get? Very different, even though they're all the same there. Now, the WIM-TB, that means total behaviours. So out of those 62, how many did they get in total? And you can just, these are the vegetative patients, and these are the minimally conscious patients. So again, all the same on the Glasgow Coma Scale, but showing a very different pattern on the WIM. Then we also, another little study we did, was the effect of posture on arousal and awareness. And we collected data from 12 patients. In fact, we went up to 21, and that one's been published. But initially, 5 vegetative and 7 minimally conscious patients. This is one of our minimally conscious patients with the physiotherapist. And this study happened by accident. It was a case of serendipity. So one of these patients, been vegetative or minimally conscious for weeks and weeks, and a colleague of mine, Agnes Shield, and the physio there, Louise, were thinking to themselves, what can we do with this patient? He's been on the ward for a long, long time. And they thought, we'll put him in the standing frame. And this man had had the WIM every day for ages. And they put him in the standing frame, and they gave him the WIM again. And he shot up. He was doing far more of those behaviours. And they'd only done it out of desperation. And it was so dramatic that all the top medics came in to have a look, and everybody came in to look at this dramatic change in this man. And Agnes came running back to my room, and she told me the story, and I said, well, is it a fluke? Is it a one-off? Or would it happen to everybody? So now, blood pressure and medical conditions permitting, everybody is stood up. And these are ranked in order of who's showing the most or the least difference. So these 3 don't show any difference between standing, or 3 of them don't show any difference. But some of them, where's the big one? This one, look, 1 lying down and 49 standing up. So they're still not fully conscious, but they're reacting to the environment a lot more. And it increased in about 75% of patients. And on a Wilcoxon match pair sign rank test, that's significant. That's pretty significant. So that's just an interesting little study of how you can start doing things very early on. And looking at those same results graphed, lying down, standing up, obviously a statistically significant difference. This doesn't look so significant, but it is. It's a statistically significant difference there between lying down and standing up. Right, then moving on to increasing use of technology to help people compensate for their cognitive deficits. I'm particularly interested in various aids for helping memory impaired people. And in one of we've done a whole series of studies on a paging system using a little pager. And one of the studies was one of the few randomized control trials in memory rehab. It's very difficult to do a randomized control trial, and you certainly can't do a double blind. But this was one where we randomly allocated people to pager first or waiting list first. And we took people from throughout the United Kingdom. They came from all 4 countries of the UK, mostly from therapists and clinical psychologists, although some were self-referrals. And we took anybody with memory and or planning problems, so the memory impaired people and the people with executive deficits. And we took people of any age, provided they could read the message on a screen. Our youngest was 8 years of age, and our oldest was 73. So they're a right cross-section of people. And not only that, the people referred to us were the ones where the therapists and psychologists had failed. Because if they'd found something that worked, they didn't need to send them into our study. So we were getting people's failures. Now, it was the system, NeuroPage, was developed by this young man's father. This is a young man who had a severe traumatic brain injury in California. His dad was a British engineer working in California, and he got together with a neuropsychologist and developed the software for this system. And it reminds me of the story that some of you may know of how the shunt was developed for hydrocephalus. That was an engineer father of a little boy with hydrocephalus working together with a neurosurgeon. But in our case, it was the engineer father working together with the neuropsychologist. And right, this is the baseline period, which lasted for, in this study, 2 weeks. So, and what happened in the baseline period is everybody had been interviewed and asked what they needed to remember each day. And it was things like taking your medication, feeding the dog, collecting your children from school, in one case, packing your spectacles. They're all real-life practical tasks. And we made a checklist, and they had to fill in whether or not they achieved that task. Well, they're memory-impaired people, so they may not remember. So we had an independent person checking as well. So we think we got fairly accurate data here. And as you can see, no difference between the two groups. Then group A get the pager, same target behaviours, same things they have to be reminded of each day, and they go jumping up. Group B on the waiting list don't change. Then Group A give their pagers back, drop back a bit, but still better than baseline. They've learned a lot of things here. Group B, meanwhile, get the pagers, and they go jumping up. So it significantly reduces the everyday failures of memory and planning in people with brain injury. And again, a little short video clip to show you one of our patients using it. And this, she wasn't in the big study, the randomized control trial. She was in a pilot study where we had 15 people. In the big trial, we had 203 initially and 143 who completed every single stage. But this is one of the patients in the pilot study.
Haley Roberts is one of 15 patients trying out a simple paging device. It's giving fresh hope to the thousands of patients who suffer head injuries every year.
7 years ago, 25-year-old Haley was in a car accident on holiday in Crete. Her brain injuries left her totally dependent on others, but today she's even looking to buy her own home. The neuropage helped to overcome the damage to her memory by reminding her what to do and when to do it.
What messages would you like on your pager this week?
Those using the device call in with all the information the patient will need. This is then fed into a computer and sent out via the pagers at the appropriate times. Scientists have called it a minor miracle. Its next step is to the Oliver Zanghill Centre in Ely, and there are hopes it will soon be widely available on the NHS.
So it really has, I think, made it a lot easier for people to be independent much sooner. It can mean the difference, for example, between perhaps being released from hospital slightly earlier than you would have done otherwise because you've learned to take your own medication thanks to using Europage.
Like the others who've tried it, Haley's life has turned around. She's gone back to college and taken up old hobbies like horse riding. But it also provides invaluable help to carers like Haley's mother.
It's wonderful for the whole family to see Haley as she is now because we never thought she'd ever be like it. And of course the neuropager, really, we've got a lot to be thankful for. We thought we'd have to keep reminding her, do this, do that, don't forget your hat and gloves, don't forget your purse, but now she does it automatically.
I've always wanted to be independent and I'm getting a second chance.
The pager could also provide financial benefits for the NHS. It may free up hospital beds and reduce the need for paid carers. But for people like Haley, there can be no greater benefit than being able to regain part of the life she lost. Judith Maloney, Look East, Cambridge.
A simple but brilliant idea.
Okay, so the final main change that I picked out of those 6 is the fact we need a number of theories to inform our clinical practice. And rehab is just one of many fields that needs a broad theoretical approach, or indeed several theoretical approaches. And if we're constrained by one theoretical approach, I believe this leads to poor clinical practice. And it's very similar to what Steve Flanagan was saying yesterday. I've forgotten it myself now, Don, he just told you, didn't he? You see what you look for, and you look for what you know. And that's true with the WIM studies too, the people in vegetative state and coma. We'd go onto wards and the nurses would say, they're not changing, they're not changing, they're not changing. And they were changing, but they weren't looking for the right things. But I think it also fits here. We mustn't be constrained by one theoretical approach. And I'll say more about this later on today, but I developed a model trying to bring all these different approaches together in 2002. Right, now finally, how far still to go? Well, I think we should try to link basic cognitive neuroscience to rehabilitation needs. I'm rather sceptical, I must say, because I work in Cambridge where 96%, I would say, of my colleagues are into imaging studies. And I'm seen as a second-class citizen because I do hands-on clinical rehab work, and they don't recognise that as having the same value. And I keep saying, well, what are your imaging studies and your neurosciences going to help me with rehab? Oh, well, you have to understand it first. You have to know which bit of the brain's damaged first. Well, you don't. I mean, telling you what bit of the brain's damaged, it doesn't tell you what goals to be set. How do we teach this man to use a memory aid? How do we help the family come to terms with this? How do we get this man the right job? Doesn't tell us any of those things, but maybe one day there will be stronger links to basic cognitive neuroscience. And so the imaging procedure is very much part of current neuropsychology, but at present I would suggest they're of limited use, except for those vegetative and minimally conscious patients. And there, I think they do contribute more because you can't observe very much behaviour and you can see what's going on in the brain, but I'll say more about that later. I think better collaboration with those using pharmaceutical interventions, and this, Don, I think was very much your area, but maybe your progesterone patients having this early rehab as well would do even better than the ones with just progesterone on its own. I think we need better evaluation of our rehab programs, and we certainly need to persuade healthcare purchasers that rehabilitation makes clinical and economical sense. And there's a lot of evidence for that. And that's our main problem in the UK. Nearly all our patients are funded by their own health authority where they live. But we have a real battle persuading those health authorities that rehab is worthwhile for our patients. It's expensive in the short term, but cost-effective in the long term. And again, there's evidence backing that up too. So the future. Well, I think one of the things the imaging procedures can do is more assessment procedures, particularly with these vegetative or low awareness patients. I think we're getting more tests from the studies of neuropsychology and emotion. This is part of the FEAST test. I don't know if any of you know that, but a very interesting test assessing recognition of emotional expressions. Pharmacological treatments, particularly if combined with neuropsychological rehabilitation and cognitive neuroscience. And I've talked to you about these three states, but let me just, as an example of how things are going here in the future, just briefly tell you about one study in Cambridge looking at 4 levels of functioning in vegetative state and minimally conscious patients. So one of the things they did was to put the patients in either the PET scanner or the fMRI and play them sound. And the question was, is there a differential response to sound versus no sound? And almost all the patients showed that. Their brain was showing a different pattern of activity to sound than to no sound. So then they went one step higher and gave more complex stimuli. Is there a differential response to meaningful sentences versus noise? Well, a smaller group of patients showed that differential response. So they went even higher. Is there a differential response to ambiguous versus non-ambiguous sentences? Very complicated this was. So an ambiguous sentence might be, there are dates and pears in the bowl, because in English, dates has 2 meanings, pears has 2 meanings. And a non-ambiguous sentence might be, Manchester is a nice place to go on holiday, Well, if you know Manchester, it's not even true. It doesn't have to be true, it just has to be not ambiguous. Now, some of them are showing a differential response here. And there are two women in the group, me and Judith Allenson, one of the medical doctors, and we started to get really worried at this. And we're saying, well, we're saying these patients aren't aware, and yet they're doing this. They're responding differently to these ambiguous and non-ambiguous sentences. And the men on the team were saying, well, we don't know that they're really aware. So they devised an even more complex one. So some patients were showing a high level of cognitive processing, but are they really aware? So they used a volitional task. Now, these people can't respond through speech or through movement because they're vegetative or minimally conscious. But they asked them to imagine they're doing a task. And the two tasks they used were imagine you're playing tennis or imagine you're moving around your room at home. And if they're going to do that, they have to understand what's being said to them, even though they appear not to be understanding anything. And they did show that this was possible in a small group of patients, small group being 2, and one of them was more clear-cut than the other. So this was patient G. Now, she met all the criteria for the vegetative state on multidisciplinary assessments, but the areas of the brain activation, when asked to imagine she's playing tennis, were consistent with the areas activated in volunteers, at least for playing tennis and moving around the room. Now, on a structural MRI, she had just a terrible brain. She had a bifrontal craniectomy, enlarged ventricles, a catheter in place, and frontal abnormality. So I'll just show you if it will come up. Okay, so you can see it's a pretty damaged brain, the craniectomy, enlarged ventricles, catheter in there, shrinkage and things. But when this patient was asked to imagine she's playing tennis, supplementary motor area up there, these are a group of controls. Spatial navigation, imagine you're walking around the room, that's the areas lighting up there, and that's the ones in the controls. So everybody got really excited about this. It was in Nature, it was in Brain, it was on British TV, and I wasn't on this paper, these were just some of the people I was working with. And the particular person, and the person who's given me the slides is Adrian Owen. So that, at least, the point of saying all that is that I think some of these assessments from that have grown out of the imaging studies may be useful, particularly for people with reduced states of consciousness. So still saying with the future, there's going to be technological advances, and I'll briefly mention SenseCam in a moment. I think neuropsychology and emotion is going to be more influential. Imaging and rehabilitation, well, possibly. And maybe brain-computer interaction, which is something that people are thinking about now. Now, just let me... SenseCam, we're doing quite a number of studies with this at the moment. It's a little camera worn around the neck of patients with memory problems and autobiographical memory deficits. And it helps them to be able to communicate with their families about a specific event. So they might wear it, for example, when they're going to their daughter's wedding or a trip to the coast or something. And they wear it, and it takes a photograph every 10 seconds. And at the end of the day, or the end of the event, they plug this into a computer, and they see a rather jerky movie. So this is how a short walk through Cambridge might look like. Is it going? No. Yes. So there's no sound, just a very jerky movie. But what this seems to do, this kind of thing, is trigger memories, particularly if they watch it 2 or 3 times. They then seem to remember a lot more about the event compared to a written diary, and it makes it much easier to communicate with their families. And we've also started to use this now in other situations, like trying to determine what triggers an anger outburst, say in people with difficulties controlling their own anger. So lots of potential works there. Now, there have been a lot of studies using imaging in rehabilitation, and some I haven't mentioned at all. I still don't know whether these really are going to be valuable for rehab. Behavioural observations can often be used to work out whether we need to try to restore lost functioning or attempt compensation. And one of my colleagues said, rehabilitation needs imaging like a fish needs a bicycle. I still sit on the fence about this. So we know imaging can identify specific lesions and areas of impaired functioning. They can determine the severity of brain damage. They can monitor change in brain functioning over time. They can show that therapy can result in changes to the brain. And they can help with making decisions, surgical decisions. And they can even predict which people are likely to remain with persistent problems. But they don't help us set the goals, how to use the memory aid, how to talk to the families, how to find the right job. Those are the things I don't think imaging can help with at present. And they cost a huge amount of money. Now, in 1996, when I set up the Oliver Zangwill Centre, they got the first PET scan in Cambridge at £8 million, over 12 million euros. And they got that with no problem at all. And I needed £300,000, a fraction of that amount. And I had a real problem getting that money. And at the end of the day, who's helping more brain injured people? Who's getting more of them back home, back to work? It's not the imaging people. So that's why I get a bit cross working in Cambridge. I'm going to leave this bit because I think you've had enough of this. But I'll just end up with this one area where I think neuroscience could prove valuable, and this has come from INSERM in Paris. Many of you will know about Jean-Dominique Bauby, the man who's had a locked-in syndrome and wrote The Diving Bell and the Butterfly. People familiar with that book? And he had to write the book via a friend who was pointing to letters, and Jean-Dominique Bauby blinked every time the right letter appeared. So the whole book was written blinking to these letters. Well, that group of people, I think, could certainly maybe benefit from brain-computer interaction. So those, particularly with locked-in syndrome, who are awake and aware but unable to move or communicate, possibly for those in the vegetative state. And this just one example from INSERM in France, in Paris, talking about open vibe, a brain-computer interaction. So when the physiological activity of the brain, from EEG or fMRI, is monitored in real time, feedback can be returned to the subject and he or she can try to exercise some control over it. So in this example, you show letters to the person and he or she looks at the one that he wants to use to spell out a word, in this case H. And Open Vibe can detect the column there, but not the row. So first of all, it detects the column, then it detects the row. So it has to be H, so that's the only one that's come up twice. Then it goes to the second letter, and so on. Right, so that's maybe another area for the future. But let me just conclude now. There's plenty of evidence for successful rehabilitation programs. We need many theoretical approaches, frameworks, models, which I'll be saying more about later this morning. We need better evaluation and not just randomised control trials. Certainly double blinds are impossible. They're fine for drug studies. But you can't use them. You can't make a therapist blind to what she's giving or a patient blind to what he's receiving. You can have single blind assessors. But Keith Andrews once said, and I love this quote, "The randomised control trial is a tool to be used and not a god to be worshipped." But rehabilitation makes clinical and economic sense. For those of you who don't know about our special interest group in Neuro Rehab, I want you to all to join. It's affiliated to the World Federation of Neuro Rehab. That's the website. Costs €30 a year to join it. Then once you've joined it, you can go to any special interest group for free, including our one. The next meeting's in Krakow in Poland, July 5th and 6th, 2010, with Jim Marlek as the programme chair. The call for abstracts is actually now out, Jim, isn't it? It's now out. And as Steve Flanagan and Nick showed you their dogs yesterday, I thought I'd show you my grandchildren, Rosie, Francesca, Samuel and Maximiliano. And with that, if Harry stole.
Thank you very much, Professor Wilson. Is there any question or comment?
Okay.
It's so clear. So, coffee break.